Other follow-up questions while we wait for our final panel member? So I think so far everybody else has been up. Pat Kyung, you've spoken, Rike and Charles. So Patricia, I think you're the last panel member and the only one that has yet to be introduced. So it's Patricia Sadian of, how's my Spanish? Argentina. That was cheating. Right, so what I'm going to do is invite each panel member to speak for 5 minutes, and we once again have some clear questions that they've been asked to speak to, and they've been very well briefed. So just to remind you, the questions we have in mind for this session are: how well does the current guidance, regulation and tools address the need? And I think we started to bring that out in the last session. What gaps remain, and can we identify creative solutions? And just to be aware, I am expecting audience participation. I know it's after lunch, but listen, because I hope that this should be an interactive session at the end of the 5 minutes max. Patricia, are you happy to go first?
Well, I think the innovation that implies greater efficiency in a clinical trials is always interesting and a great challenge for regulatory national authorities and also for ethics committee. However, in some way in my country, and I feel in Latin America, innovation and alternative design are seen more in terms of obstacles than a challenge to use more efficient trial design to answer a research question. Even more, some staff member of the regulatory national authority saw that this type of trial are only a resource of the pharmaceutical company in order to reduce the time in the drug development program. And why the staff of the regulators and why many members of ethics committee think like that? I think it's because we have very limited experience in Latin America, and we have lack of guideline and regulation. So I feel Latin America need to start in the region the discussion about what are these alternative design, when to use this design instead of the randomized clinical trials, and mainly how to evaluate and interpret the efficacy data and the safety data. Can we use some new development to help the regulators in minimize the positive, erroneous positive conclusion when we use adaptive clinical trials? How we use some development to help in dose escalation studies and in order to avoid some safety concern? Well, I think we just need to start, but not. The question is, we need in the region to write a new guidelines about alternative trials? I think not, because what is an alternative trial, when we can use that, how to evaluate, is the same in high income countries and in low and middle income countries. What is the problem? The problem is we have very limited training human resources and staff of the regulators and the ethics committee to interpret those current guidelines. We have guidelines. We have the FDA guidelines, the EMA guidelines, we have the Ottawa statement. We have, mainly when we will write a guideline and consort develop first a new guideline. We have guidelines, but we don't have resources in order to analyze the data. It's for that I think PAHO, Pan American Health Organization, through the Pan American Network of Drug Regulatory Harmonization and the bioethics program, could play an important role putting the theme in the agenda of the regulators, because it's not now, and training the regulators, staff, and the ethics committee members, and assuring cooperation between countries in the region which have experience, like FDA, like Health Canada, and the rest of the countries.
Great, thank you, Patricia. I think you've also given Carla some work there, even though I think she was trying to get out of it without guidance, but I think your point about training is well taken, and I think Carla was listening intently there. I will move on to Pak Kyung. What we'll do is just take everyone speaking, and then we'll do questions and comments at the end. can clap each speaker. So I do like the phrase responsibly creative, or creativity. I'd like to bring that out in the discussion and find out what we think's acceptable, responsible creativity. Rika's next. She's been very lucky this afternoon because not only did we make her do the background research as to what guidelines are out there, we're also going to make her address the questions as to what we should be looking at. So without further ado, Rika.
How to establish those specifications. In my talk, I said, well, we need the help of international organizations to assist us in writing documents that can clarify the issues and issuing those guidelines. But perhaps I should modify that statement saying that's a really aspirational goal. It may work within 5 to 10 years from now, but not at this moment, not in when these alternative trial designs are increasingly being promoted. So there's direct help needed and what to do in the meantime. We may think of MOOCs, of very short training courses funded by perhaps Fogarty. We could also think of key points to be published on easily to access websites, for instance, Welcome Trust. So just things that can be done in the short term. But it's also important then, and that's my third point, to consider whom we need to address. And perhaps we shouldn't think of one-size-fits-all approach to solve the issues at hand by solving it in one document or one guideline, because there are different stakeholders at the table, and perhaps pharma or trialists need other approaches than researchers or research ethics committees considering those trial designs. So I think we should come up with tailored solutions, whatever those solutions may be.
Fantastic, thank you, Rika. So a call for further specification. An interesting point about short-term easy wins, as we've got issues to address now, and thinking with a longer-term perspective, could we ask for and advocate in the long term? I think the one-size-fits-all question is really interesting because I think Christina brought that out in the context is important. What scares me about not trying to get something that is at least as generalizable as possible is we're increasingly doing collaborative international research. So I think any solutions we look, they have to be generalizable yet context specific. And research that we fund, we'll fund to a certain point as a research funder, and then pharma will take up that research. So there has to be continuity. I think we need to think about our audiences, but lots of food for thought. And without further ado, Charles, last but certainly not least.
Thank you. I think this is an enormously exciting and important moment in research ethics. And so kudos on arranging this meeting on this topic at this time. I see really two broad trends kind of going on at the same time that are new in ways, and I think important. One is kind of a pragmatism in health research, where increasingly we're realizing that the ways in which we've been doing, particularly drug trials, aren't sufficiently responsive to the needs of patients, communities, health providers, and health systems. And we're seeing that we need to do trials about more things than just drugs. We need trials that address policies, about health service delivery, and this pragmatism movement to me, I think poses a fundamental challenge to research ethics in that it blurs the distinction between research and practice. So that's one broad trend that's been going on for the last while. The second one is related to it, and that's the explosion in innovative designs. And some of that has been driven by pragmatism, right? Trying to, how do we sort of get better answers? How do we evaluate policies? How do we evaluate sort of public health interventions? And some of that is driving these innovative designs. But those designs in themselves, as we've heard over the last 2 days, raise really difficult ethical challenges. So both of these things are going on right now, and they're both interacting with one another. And I think together they pose a very fundamental problem, a fundamental challenge to all of us who care deeply about research ethics. So this meeting is really most timely, and I really wanted to highlight the scope of the problem that in fact we're facing. I'd like very much comments from the audience about how we have good ethical principles, about how we have outstanding guidelines documents, and that's a really important place for us to start. But I think because of these new challenges of pragmatism and innovative designs, there are gaps. Right? It would be very difficult to just sort of take a set of ethical principles and look at a cluster randomized trial for the first time and just sort of figure out what to do. And it's because features of that design raise new problems that the authors of those principles originally had not ever anticipated. Right? So I think we do need new guidance. But I think the really difficult question is how to do that. I think part of the answer is really sort of simply stated, right? And that is that this is a kind of complex social problem that just essentially requires an interdisciplinary solution. So kind of just like the people in this room, the solution requires all of us coming together. People from communities, patient representatives, health providers, biostatisticians, ethicists, and others need to come together to craft these solutions. But the other part of the problem, it seems to me, is more difficult, and that is how do we, given the changing nature of, designers are going to continue to innovate, and pragmatism is going to continue to evolve as well. How do we strike a balance between being nimble on the one hand and being authoritative on the other? It's very difficult to have both. And so I think that's a really difficult problem. With the Ottawa statement, we sort of, I guess we erred on the side of nimble, and we just got together and we wrote a bunch of stuff published it. We just sort of hope that people would find it useful. And so I think there is a role for that. But how can we do that better? Can we work with funders so that there is better uptake of these nimble solutions? One model that came to mind was many of you will know the Consort reporting guidelines that provides sort of a foundational kind of framework for reporting of randomized controlled trials. But as new trial designs come along, they come up with extensions. And I was kind of wondering if that sort of Consort extension model might be something that's appropriate for innovative designs as they arise. The final point I'll make is that new guidelines just aren't enough, right? I mean, I think there's a huge educational need globally in low and middle income countries and in high income countries too. There's a global need for education about these new challenges. There's a global need for face-to-face workshops, the development of online tools to really support researchers, research ethics committees, and communities as they deal with these problems.
Thank you, Charles. I think the interdisciplinary nature of this problem has come flowing through every talk. I mean, it's the statisticians that are driving the change, and we've got a unique opportunity because they're in the room. So first, I'd like everyone to stand up and then sit back down again because I can see you falling asleep. Go on, do it. That wasn't informed consent either. And then I think we've got a lot of food for thought. So let's open it up and just think how we can take the next 6 months, 12 months, 2 years, 5 years forward. So we walk out of this room with some kind of ideas on how to come up with solutions. I think that highlights the problem. We cannot be chasing the innovation the entire time with trying to amend guidance. We need to think on our feet, and we have a unique opportunity to do it now. So questions, thoughts, please.
Right now, I must say it's been a very hectic 2 days of brainstorming and discussing research. I must confess that. And beautiful things, innovations, which really mind-blowing. I'm going to be speaking like an African with peculiar challenges when it comes to research. I'm sure that the current GCP we are using for clinical trial or clinical research was adopted in 1996 and been modified severally by different countries. One of the issues there that was developed by the European Union, the Japan countries, and the America, US. I'm sure my colleagues from Africa have already noted earlier that most of the Africans generally had little or no input into such documents. And so currently, I don't know about any African country, but I know of only South Africa that has domesticated the GCP document that was developed in 1996 to real local applications. So to me, as a researcher in Africa, I see it as a very big challenge that a lot of African countries other than South Africa has gone ahead to domesticate GCP, putting into consideration your local content as it affects the people. So what's the way forward? I propose 3 things here. There is a strong need to train and retrain all research experts in Africa. I don't know how the organization is going to do it. I don't know how they're going to design it, but it's going to be maybe stratify the training. Maybe train grade by grade, maybe ethical experts, regulatory experts, data managers, and different other groups who are involved in clinical trial. We need it Because most of the things we are discussing here, I designed a protocol to do clinical trial with moringa for the treatment of hypertension. We had a lot of issues getting it approved by ethics committee. They were of the opinion, why not go fix, do clinical trial, do animal experiment? I said, there's no need for animal experiment. We are not designing preclinical study here. We are designing clinical trial, and everybody takes moringa. Everybody knows what moringa does. Why should we go back to it? It was a big discussion. So imagine bringing an idea of coming to Africa and say, I want to fix somebody with syphilis or pneumonia, how it's going to react to it. But if they are taught, and if they are brought to the same book, justified, then they can come to the same page. So I propose a good training. Now, adaptive research designs and every other one requires strict monitoring. So I want to propose that there should be adequate and increased monitoring oversight of maybe CRAs, data monitoring committees, and ethical committees. The thing we have now is just ethics committee approves a protocol, and they don't go back to the field to find out what happens. And most clinical trials don't even have safety monitoring committees. And these are gaps. So to move forward in this novel approach of organizing clinical trial, there should be need for safety monitoring committee to be established, who will have oversight function to visit sites. And there should be well-trained experts in CRAs who also will increase oversight function in monitoring. I want to also propose that developing new regulations and guidelines for adaptive clinical trial designs should be done in collaboration with research experts in Africa, because they'll be able to view issues the way it affects Africans. We're talking about gatekeepers. A single community chief can destroy a brilliant research idea that you have because he doesn't want to buy into it. And once the community chief says that none of the members of the community should participate in a research, in spite of your brilliant idea and novelty, that research can never be pushed forward. So we have such problems. So these are issues. So community engagement, community consent, communities buying into the research should be put together when such guidelines are being developed. And those will have to be called forward to also profile ways of moving things forward. Finally, quality issues in clinical research, which definitely we know is GCLP. And the issue of GCLP is also an issue in Africa, and that has to be brought up when monitors go to the field to really find out labs vis-a-vis the data they are collecting, whether it's compliant with regulation. So these are my submissions as per these areas. Thank you.
Thank you. What I'll do is I'll take maybe 3 or 4 comments and then invite comments back from the panel. Ross, would you like to go next?
Yeah, thanks. I was heartened by Charles's comments on the need to embrace more pragmatism, and I think pragmatism in the true sense. So pragmatism's a theory that gets a bad name, but I've spent the last few years studying the work of Charles Saunders Peirce, who is actually, so what we're after is reliable inference in the design of our science. Whether it's statistical or not is another matter. So it's how you eliminate false hypotheses. But we also need to be more pragmatic in our ethics in the Peircean sense that the goals that we're establishing and the way that we evaluate the means to those goals is the best possible way of achieving those goals. So there's no rivalry between sort of the epistemic claims of pragmatism and their normative claims. We can do both. And just to pick up, and so we all have to up our game because we're going to be all engaged in learning a lot of new things. Because even the statisticians, I think, are a little leery of the machine learning applications, at least in my school when I talk to the biostatisticians. All of the data analysis is going to be put into a machine, and they're not really sure what's going on there. So there's not one person in the room that I think has the security of either the epistemology of the future or the values of the future. I think we have to be truly pragmatic in the sense that we're a community of inquirers. We're going to learn together. And if we go back to the traditional way of siloed thinking that kind of predominated, I would say, in schools of statistics for a long time. You're either a frequentist and you had you held the stage and you taught Neyman Pearson hypothesis testing as the scientific method, and that was the way we were all taught until the recent advent of Bayesian approaches. And Bayesianism is in ascendancies now, and we see some of that thinking here, but who knows what's next? So I think fora like this, where people are actually struggling with the ideas, we will always be provisional and fallibilistic in our approaches, and that grates against some of the universalists in the ethical world and the imperialists of certain forms of data analysis. I think nobody here should feel secure. We should all have our continuous professional development and continuous education hats on, and we need fora like this to communicate ideas and adapt strategy. So we need adaptive ethics and adaptive trial designs.
Thanks, Ross. Mike?
I'm now feeling very insecure. I guess that's appropriate. What was I going to say? Oh yeah, I think the important thing here as well is that there's not one single solution to this. So, of course, ethics committees and those concerned with the oversight of research need to find ways or be supported in ways developing their understanding of trial design to be able to engage with that. And it's important that there's a critical ethical consideration of this kind of work. But I also just wanted to, something that hasn't really been said so far, I don't think, is that we do need to find new ways of doing ethics. So I guess it comes to Ross's point. And I think one of those ways is that I think ethics has in the past tended to be wary of getting too close to science. And I think we need to actually find ways of embedding ethics in science so that, this is not, as I say, this is not the only thing that ethics should do, but one thing that ethics should do is be built into science so that these considerations can be thought of at an early stage, and that scientists and their ethics partners are in a position throughout that process to engage in conversations with ethics committees and so on and funders to work out, what are the ethical considerations and what are possible solutions and so on. So I think I'd want to advocate a bit more building ethics into science.
Any other comments before I pass back to the panel, please?
Thank you. That there is a gap in the guidelines we have, I think it is now obvious. Gaps are there. That we need capacity building, I think that one is obvious. But I'm proposing this. Before we talk about capacity building, we need to have a consultative forum where the major stakeholders will be brought on board, so that we are not talking about the GCP where there was Japan, USA, Europe, and Africa was left out. So that we have the big pharma, we have national institutions at national level being engaged, they give their views, and then we think of changing the guidelines. So that at least we have the input from the major stakeholders before we do the changing. Thank you very much.
Thank you. Florencia, final comment from the audience. I think we're going to run out of time. I think what we're all saying is that there needs to be some practical solutions, some changes to the way that we behave, both as ethicists and scientists, more integration into it. Some very short term, I think some of the training we could look at, some very practical things. I think there are some bigger systemic things in the way that we operate our work. But Florencia.
Well, maybe what I want is a word of caution in the sense that we have to be practical, but I think that there is a tendency, maybe I'm repeating myself, to go through checklists and try to solve everything through checklists, and research ethics committees love checklists. And I think that what we really need is deep thought, so we can understand the different situations, the different contexts, when one trial really applies and one design can be accepted and another not. So we have to be really cautious in not going through these easy, ready-to-use things, but trying to make people aware of their responsibility and of the deep thinking that this implies. There are guidelines. There are some resources. We can work through them. But still, I think there is a very prevalent tendency to use and to think through checklist the easy way, and so informed consent, vulnerable population, this. And this is not the way. We have to frame it in another way if we want to do it seriously, to take in consideration really the context.
Any final comments from the panel? No?
I think, like Florencia said, I think regulatory authorities, ethics committee members, and also investigators in Latin America need more the base of the problem, need training, but deeply training. Don't need checklists, don't need more guidelines. They need that because they don't need fathers. They need to make their own decision. That is my position.
Yeah, I just want to pick up on Mike's point about the importance of, and Ross's as well, about the importance of a kind of pragmatism and ethics, and really that we need to start training ethicists in a new way. And so I work in a philosophy department, and I train young philosophers like Corey Goldstein, who's my doctoral student. And sure, they get a standard philosophical education, but all of my doctoral students are embedded with scientists, right? They work with teams of scientists. They learn how to talk to biostatisticians. We're increasingly now involved with patient and community representatives with our groups, and I think that is absolutely the way forward. We have to see ethics as something that's fundamentally interdisciplinary and engaged.
Please, final word.
Just very quickly, two things. There was a comment made, I think you made it about a consort extension for adaptive designs. There's an active process going on in the UK. It's a Delphi process for exactly that. Great idea. Other people are running with it. And there was this article that just came out in the Journal of Medical Ethics by Alex London that I think was shown up. I'm going to go up and put the abstract up as soon as the panel is over. I urge you to read it because I think it's a wonderful example of exactly what you're talking about. Deep thought, good solid philosophy, ethics applied to a very practical problem.
I'm going to give Pak Yong the final word, partly because she's the co-host. This is... it's a quick, Rika first and then Pak Yong.
I know we can't distribute the article. I sent it to Adrian last night, but it is not open access. But I know that if you send Alex London an email, he will send one copy to you.
And I'm happy to send my slides to anybody who emails me.
Go quick.
I just want to say that, so I hear the call for training and capacity building, etc. I just want to say that Christina and I have a cunning plan and we'll work something out. But what I want to say is, and hearing from what you mentioned, there's a lot of thinking that should go into it. So it's not training. We're going to bring these conversations to other forums like FERCAP.
Thank you. So that's the final word for this session, but I think it's not the final word on this topic, and it feels like a great topic for a fellowship. Food for thought for people in the room, the people to go and visit. So we've got 20 minutes for coffee, and then please be back at 3:30 for the final hour and a half of this super stimulating meeting. Thank you all, and thanks to all our panelists.